I'll briefly mention another abstract, also an analysis of the UNITE study that was actually presented as one of the rapid oral presentations just earlier this morning. That was an abstract by Amanda Nizam that looked at the activity of enfortumab vedotin in patients who had received switch maintenance avelumab therapy. So basically patients who had platinum-based chemotherapy, had clinical benefit from it, so response or stable disease, which made them eligible for switch maintenance avelumab, and then upon progression on switch maintenance avelumab, then received enfortumab vedotin. So this is, of course, a somewhat different population from specifically the setting in which enfortumab vedotin was approved as monotherapy, which were patients who had progressed on platinum-based chemo and then an immune checkpoint inhibitor. But what we actually see in this abstract is that outcomes are about what you expect with enfortumab vedotin. So response rates of just north of 50% in this retrospective study, 54% I believe, with a median progression-free survival around 7 months, median overall survival about 13 months. So again, pretty consistent in this patient population. And again, highlights that in this treatment setting, which will still be relevant even with with the approval of EV-pembro and many patients getting that, enfortumab vedotin can be used as monotherapy. I will then maybe pivot a little bit to another abstract that Guru, maybe you can mention, and that's well, actually a couple of abstracts. There was a compelling abstract of two compelling abstracts of combination therapy, and so I'll let you talk about those.
On the heels of the DAD trial, which we showed at ESMO, which was a combination of two ADCs for the first time, enfortumab vedotin and sacituzumab, the 70% response rate. There's a couple other combinations here at this meeting. So one is the cabozantinib plus pembrolizumab combination in the first line cisplatin ineligible PD-L1 high or platinum ineligible, or they were cisplatin platinum refusing, basically, platinum refusing. So in this population, cabo was combined at a 40 milligram daily dose with pembrolizumab. And suffice it to say that it's a small study, 36 evaluable patients approximately, and the response rate was close to 46%. That's high. The complete response rate was around 14 to 15%. So this comes in the context of, if you remember, the lenvatinib plus pembrolizumab first-line trial, which was negative compared to pembrolizumab. That was a poor patient population, 80% of patients at PS2, mostly platinum ineligible. So there was a doubt that this was an unfit patient population. So I would characterize this pembro-cabo population as being more fit than that, although it did have a majority of platinum ineligible patients. It also comes in the context of other data with cabozantinib plus atezolizumab, which was a second line or greater line trial where it did not quite look as robust. The response rates were in the 25% or so range. So the question arises, is cabozantinib plus pembrolizumab a more optimal VEGF inhibitor plus PD-1 combination? It could be potentially biologically. Cabozantinib can inhibit some of the TAM kinases, the tyroaxl MER. Maybe it's more immune enhancing than lenvatinib, and maybe pembro PD-1 inhibition is better than atezolizumab, a PD-L1 inhibitor, just as a thought. So I think that this needs to be still teased out. So I would not write off VEGF inhibition alone or in combination with the PD-1 inhibitor. Could cabo play a role in this switch maintenance situation with EV pembro starting patients who have to stop EV for neuropathy or other toxicities? Can we switch to cabo while continuing pembro? So these are things we need to think about. So that's one combination. The second combination I want to highlight is the combination of EV and Erdafitinib. This was done in patients with FGFR3 or 2 activating mutations or fusions. At this point, it's just a phase 1 study, and this data here on 8 patients. So we used the full doses of Erdafitinib, 8 milligram. That was assumed to be the standard preferred regimen for FGFR3 or 2 altered patients. And then to that, we added EV, the reduced dose of 1 milligram per kilo, and then escalated to 1.25. So here we have data on 8 patients so far in the phase 1 escalation phase. It was tolerable with the expected toxicities, as you can expect with the Erdafitinib and the EV, with the skin and the stomatitis and the loose stools, diarrhea. But 8 out of 8 patients had a partial response. So that is really striking. Of course, there's only 8 patients, so I think that we need to get a better handle on the safety and the efficacy, of course, with a larger number of patients. Where do we go with this? Can we combine this with pembrolizumab, EV pembro plus Erdafitinib? Or could the similar role for Erdafitinib switch maintenance combined with pembro, omitting the EV after around 6 months? Could that play a role? So I think we need to think about this.
Are you worried about the skin toxicity, the combination of EV and Erdafitinib?
Yes, but I think that we have to get some more data on this. I mean, Erdafitinib is not highly skin toxic. Yeah, you can see skin toxicities, but EV obviously is a concern, so we need to watch for that.
Yeah, a lot of compelling data there, especially with these newer combinations.